Can I ask you that? Thank you. Okay. Let's see if I can get this to work. And I also want to just also the material that I'm going to be presenting in these sessions are actually going to be the basis of a textbook chapter that I'm going to be writing as an associate editor in the Bible of Clinical Pathology by John Bernard Henry, called Clinical Diagnosis and Management by Laboratory Methods. It's going to be show you how to correlate laboratory values, and so you'll be the first ones really to be the beneficiaries of this. I don't mean to seem immodest, but whatever value it has, at least you'll be the beneficiaries of it, if there's any at all. Now, as far as I'm concerned, you're here because you want to learn this material. I'm not taking attendance. I think we're all beyond that. Therefore, just for showing up, I'm going to give everybody honors. I assume that you'll just make the maximum effort possible. Whether you're here or you're not here, it's up to you. It's completely the honors system, literally and figuratively. I want to just put that behind us now and get on to describing to you what we're really going to be doing here. First of all, let me just state my philosophy of medicine, which I can state very simply, that as doctors, and you're really all doctors now, it's just a question of you're learning more and more, become better and better physicians. So you're starting at the beginning. You're beginning doctors right now. My philosophy of medicine is that we must do everything we possibly can do for all patients, no matter who they are. That's it. Now, the next statement I'm going to make is going to seem to contradict that. And that is, you can actually, from the materials that I present you with today and next Thursday, make the diagnosis of what is the cause of a patient's illness or illnesses without ever having to see the patient in about 80% of those patients for whom you will have laboratory values, if you handled it right. And I'm going to try to show you in these two sessions how to handle it right. Now, that does not mean that you should not examine your patients and take a history. That you must do. It's extremely important. Physical contact with patients is the basis of all medicine. It is all the part of the art of medicine. But what I want to show you is, for example, if a patient has some kind of an arrhythmia that just suddenly started up, and you wanted to determine whether or not the patient is really having a heart attack or there was a silent MI, you want to know what lab test should you order. I mean, you're not going to get a sodium on that patient. Maybe you will for another reason. Most patients get that anyway, but you're not going to order, for example, a beta-HCG, a pregnancy test. You're going to order a CKMB, as we spoke about in one of our lectures. So I wanted to discuss that with you today also. So it's going to tell you what to look for. But more importantly, when the laboratory tests come back, you will find out next year that most of the clinicians do not look at the results. Or if they do look at the results, they're not going to look at them critically. As I'm going to show you today, the patient may have an anemia. Now, what we'll get in the lab is and it's good for us, I'm happy it happens, they order all the possible lab tests you can to work up an anemia. That's great because you bill and you get reimbursed, at least so far. I don't know what's going to happen in the future, but the fact is that you don't have to do that. There are specific things you really want to look for. If it's what we're going to see in a minute, it's a hypochromic microcytic anemia. There is one test you want to order first and foremost, and that's ferritin. And I'll show you why in just several moments. There's a very good reason for it. And that's the test you want to order. You don't want to go and get an RDW, and you don't want to do an iron binding capacity. You can get those results, too, to confirm what you suspect as being the cause, but the ferritin is the most important test. So you've got to put your money on a certain set of tests, and that's what I want to teach you how to do. You want to be able to correlate laboratory values. A patient may have a hyponatremia, for example, and may have liver disease. Now, what could the possible cause of the hyponatremia be? Are the two things related to one another? And the answer is yes. Very often they are related. The patient could have ascites with a volume loss, an oversecretion, an inappropriate amount of antidiuretic hormone secreted to make up for that volume loss, diluting the sodium in serum to cause what we call SIADH, secretion of inappropriate amounts of antidiuretic hormone syndrome. And I'm going to show you that in a moment. Those two conditions are correlated. So I want to show you how to bring these values together and look at these things in context so you know how to make the diagnosis. You take the lab values, you make the diagnosis, and treat the patient appropriately. So this session and next Thursday will be devoted to that. Now, the following 2 sessions, we will actually go on rounds and see patients with abnormal laboratory values. Since there are about 70 people, you will be broken up into 7 groups of 10. And you will all go see different patients. Some groups will go with, one group will go with me, one will go with the resident in clinical pathology, then there'll be another resident in clinical pathology, and there are several residents in internal medicine and pediatrics. You'll all go with them, you'll have the lab values, and then you will see the patients, and you will be able to make the diagnoses. Some of them will be simple, some of them will be more complex. That will be 3 weeks from today. The last week, on the 4th week, one of 2 things is going to happen. Either we'll all get together and discuss those patients together, or you may decide we want to see another patient. So in that case, we'll set up another patient, and you'll go be able to see the next patient. So you'll see a maximum of 2, a minimum of 1. Now, of course, if you have somebody in a group, who's the case is more interesting, you can switch. Yeah, you could, switch around, do anything you want. This is a free country. You can do whatever you want to do. So basically, to me, it doesn't make any difference, but I just have to organize it so that there are no more than 10 people, because when you get up on the wards, and 10 people show up on rounds, it's a little intimidating to the staff. It's good. It keeps them on their toes. But the fact is that you'll really see how these things are put together: the clinical condition together with the laboratory values. Now, I'm going to start and tell you how to go about interpreting lab values. And you're going to, when you come onto the wards, you're going to have the patient's chart, you're going to have a history, you're going to have results of the physical exam, and they're going to be the pathology laboratory reports, which consists of 2 parts. There's the clinical laboratory report, and of course, if the patient is a surgery patient, there'll be a biopsy result, or several biopsy results, in which there'll be a written report from the biopsy. I'm going to be focusing most of my attention on the first type of pathology report, the laboratory report, and show you what happens when you get these values back. Now, the values are arranged, generally speaking, in 3 major categories, and in this order. There is the hematopathology results from the blood studies, from looking at the red cell count, white cell count. The second part is the chemistry part, the clinical chemistry. That's the sodium, the potassium, the enzymes, the liver function tests, the renal function tests. And the third part is microbiology. For example, if the patient had a blood culture or a urine culture, those are the things that are reported. Is the culture positive? If they're positive, what are they positive for? If they're negative, what was looked for? What wasn't looked for? So that's basically the way the report is organized. It's very simple. Now I want to go back and talk about each of these in turn. The first is the hematopathology. Now, in the hematopathology, you're going to be given, and I thought I would just do this, instead of using the blackboard, I would use these, we'll see how it works out. I think it'll work out all right. That's the, the overhead transparencies. The first thing the first thing I want you to look for is the red cell count. Now, the red cell count reflects the number of red blood cells per cubic millimeter of blood volume. And it's, of course, directly related to what we call the hematocrit. The hematocrit is simply that volume of the total amount of blood that you get from a patient that's occupied by cells. And those cells are 2 types of cells, red cells and white cells. Now I want to talk about the red cells first. You can get one of 3 results. It's very simple. Either the cell count will be normal, the cell count will be high, or the cell count will be low. Now, if the cell count is normal, the patient does not have an abnormal count, no matter what. Therefore, he does not have polycythemia vera, and he doesn't have anemia, the high count or the low count. Let's suppose that the red count is low. Then by definition, if the red count is low, the number of cells per cubic millimeter is low, the patient has an anemia, by definition. That is it. That is all you have to worry about. Once the patient has an anemia, and you've established that, and you look at one number to establish that, then, after you've made that decision, you want to know what kind of anemia does this patient have to take appropriate action. Now, what do I mean by appropriate action? Well, a patient who has a macrocytic anemia due to the fact that he's got a nutritional deficiency is a patient you don't want to transfuse. It is stupid to transfuse a patient like that, especially nowadays. when you have a risk of giving the patient AIDS or hepatitis. Why take that risk if you don't have to? That's the first thing. On the other hand, the patient may be bleeding, in which case you don't want to give him vitamins, but you want to give the patient a transfusion. Now you have to transfuse. Well, it's obvious that the therapy is going to be very strongly dependent on the diagnosis that you make. Therefore, we want to look at the types of anemia that the patient can have. Now, we divide the anemias up. This is, let me show you how this is done. This is a very bad slide, and I should have rewritten this, but I did it in the back of a car. I want to show you basically what's going on. The slide does illustrate the point I want to make. Cells have color and they have size. That's the only two things you have to know about red blood cells: their size and their color. Now, the color is what we call their chromicity. That makes sense, chromic. Okay, and they could have normal color. They could be, their color could be, they should look red, nice and red. They are red cells. They could look, have very little color in them, in which case they're called hypochromic. If they have normal coloration, they're called normochromic. And finally, if they have too much color, they're too red, we call them hyperchromic. Now, what about the size of the cell? Well, there are only three possibilities for that, too. They could be normal size, they could be too small, or they could be too big. In which case, if they're too small, they're called microcytic. Otherwise, they're called normocytic. Or finally, they could be called macrocytic if they're too large. Now, take a look at this. You have an anemia. We classify the anemias by the cell color and the cell size. Now, cell color and cell size should give you 3 times 3, or 9 combinations of types of anemia. That's rather hopelessly complicated, 9 types of anemias. But it turns out nature's been very kind to us. Of those 9, we actually only have to recognize 3. And those 3 are sort of shown here: hypochromic microcytic, normochromic normocytic, or macrocytic. If an anemia is macrocytic, you don't even have to bother to look at the color. That already gets rid of 3 right there. A macrocytic anemia has a very well-defined, beautiful, it's very, very simple, and I want to show you how to work this up. Very neat and simple way. Now, let's first talk about the anemias in this order. Let's talk about hypochromic microcytic. But before I go on, I want to talk to you about some numbers. Now, having presented it to you this way, I have some slides to show you what each of these 3 types of anemias look like on a slide, so we can review that, but I don't want to quite do it now. What I want to tell you is that you don't have to look at the slide. You can look at the numbers, because we have cell counters which actually look at the slide for you and tell you the average cell size is this. And in fact, not only will it tell you the cell size, it'll actually give you the distribution of cells that have that particular size. And draw out a complete histogram for you, so you can actually see what the distribution of cells is for the patient. We're going to talk about that in more detail in just 5 minutes from now, or less. Now, before I go into that, what do these numbers mean? What numbers should you look for in order to determine the chromicity and the cytosis of these cells? Well, the answer is there are two numbers that are given. One is called the MCV, and the other is called the MCHC. MCV is mean corpuscular volume. The MCHC is the mean corpuscular hemoglobin concentration. MCV and MCHC. Now, corpuscular just means, it's the red blood cell. It's a doctor's way of saying red blood cell, corpuscle. And MCHC, the mean corpuscular hemoglobin concentration, is the average hemoglobin concentration per red blood cell. Now, of course, it is the hemoglobin that's giving the color to the cell. These are the 2 quantities you want to look at to determine what kind of anemia it is. Now, remember, the patient does not have an anemia unless the blood count is low. What are normal blood counts? Depends on the lab that you look at. I will give you some numbers. Just sort of back of the thumbnail type numbers you can use off the cuff. 4 to 6 million red blood cells per cubic millimeter is, generally speaking, the normal range. For women, it's slightly lower. For men, it's slightly higher. But this is the mean. and it may depend upon the specific population, but it'll always hover between 4 and 6 million. Now, if a patient has a count of 2.5 million, the patient has an anemia. The very next thing you look for is what? The very next thing you look for is MCV. The MCV is going to be high, normal, or low. After you decide on what that is, you look at the MCHC. That's going to be high, normal, or low. MCHC is going to give you the chromicity. So if it's a low chromicity, if the mean corpuscular hemoglobin concentration is low, it is already a hypochromic anemia. If the cell size, that is the MCV, is low, then it is already a hypochromic microcytic anemia, one of the 3 major types that I mentioned to you just several moments ago. So those are the 2 numbers you want to look at immediately after you see that there's an anemia by looking at the red blood cell count. Is that clear so far? Okay, now, let's take the 3 cases individually. By the way, just to give you again some numbers, if you have a red cell volume between, say, about 85 up to about 96 femtoliters, and a femtoliter is 10 to the minus 15th liters, very small, that's the average corpuscular volume of a red blood cell. MCHC, you know what that is. That's usually around 33, 34 grams per deciliter of hemoglobin. That's the usual concentration that you see. If it's lower than that, and by the way, the ranges are always printed out on the report, so you don't have to commit these numbers to your memory. Look at the report, look at the range, look at the value, and decide, is it in the range or is it outside of the range? If it's outside the range, is it high outside the range? Is it low outside the range? Sounds simple, but most people don't do this, and it's amazing. It amazes me every single time I see it. You have to do that. Very simple things to do. They take seconds. And you can get the answer right away. Just looking at the numbers. All you got to do is look at the numbers. Now, let's take the 3 cases. Suppose it's a hypochromic microcytic anemia. What are the possible causes of hypochromic microcytic anemia? There are 3, and only 3. Let me show you what those are. The next slide's a little bit better. Here it is. There are the 3 causes right there. And those 3 causes are, the first is thalassemia. Now, thalassemia is not a cause of anemia, generally speaking. But you will often see people come down totally confused. My patient, I think, has a history of having beta thal or alpha thal, and has a normal red blood cell count, but it's a hypochromic microcytic anemia. Well, if the red cell count is normal, it is not an anemia. Actually, thalassemia is usually accompanied by a low normal red blood cell count and a hypochromic microcytic condition. So it is not a true anemia. Thalassemia is not, generally speaking, going to cause an anemia. It's an abnormal hemoglobin, but it doesn't result in decreasing the cell count. You produce enough hemoglobin to fill up the cells, there's no problem there. Far more serious as a cause of hypochromic microcytic anemia, and the most common one that you will see is iron deficiency anemia, IDA, iron deficiency anemia. Now, what do we mean when we say iron deficiency anemia? It's a very simple concept. It means that there is no iron left in your iron stores to fill up red blood cells. Well, if the red blood cells can't get it, they shrink. They shrink because if there's no iron, there's very little hemoglobin. When there's little hemoglobin, the chromicity goes down. Because there's no hemoglobin and no iron inside the red blood cell, which is being made, the cell shrinks. So you have a hypochromic microcytic. It's given to you on a silver platter. Now, what causes a depletion of the iron stores? Simple. By far and away, the most common cause of a depletion of iron stores in the body is bleeding. You're losing red blood cells because red blood cells are going outside the body, and the body cannot compensate fast enough for that loss. And as more red blood cells are being demanded, the bone marrow is consistently producing red cell precursors. There's a high so-called reticulocyte count. Reticulocytes are those cells which are just precede red blood cells, the stage before red blood cells. They've lost their nuclei, and they're just about to shrink down and give you the normal corpuscles, the red blood cell corpuscles. It's that once they have a lot more mRNA, and you can actually stain for that mRNA and pick it up on a stain. Methylene blue works beautifully, by the way, this way. It's the way we determine what the reticulocyte count actually is. And at any rate, the point is that the red blood cell, reticulocytosis, the red blood, the body's still trying to produce these red blood cells, but they're not getting enough iron because as it's producing more and more cells, you're losing more and more cells, iron's being used up, and the body can't replenish its iron stores fast enough. So we have a ready-made way of being able to diagnose IDA. And it's very simple. All you got to do is do a bone marrow biopsy and then stain the bone marrow for iron. And if you don't see any iron there, it's iron deficiency by definition. That's it. And the diagnosis is over. You've made it. There's a problem with doing that, though. There is a morbidity associated with doing a bone marrow biopsy because you have to put the patient on his stomach. He may be debilitated. You got to go in and take blood out of a patient. You got to stick a trocar into a patient to get his bone marrow. It's painful. And if the patient is already bleeding from somewhere, well, what if he has disseminated intravascular coagulopathy, something like that, where he's losing lots and lots of coagulation factors and he's bleeding into all his tissues, his platelet count is dropping. Now you're going to go in and do a biopsy, an invasive procedure on that patient? That's crazy. That's a really stupid thing to do. That's bad. You don't want to do that. Anytime you can get around doing an invasive procedure, you do it. And our labs are set up so we can avoid doing many procedures. Remember when I talked to you about liver function? We had a micro exam that day, but some of you may remember that I mentioned how you could use liver function tests, and you can interpret the tests and not even bother with a liver biopsy because you know the diagnosis without even looking at the liver. And that's what we strive for in the laboratory and what I'm trying to get across to you here. So we want to have other tests other than a biopsy that will allow you to make the diagnosis. Of iron deficiency anemia? And here's the way we do it. The most important test, as I mentioned to you by way of introduction, is ferritin. What is ferritin? Ferritin happens to be a protein that binds very tightly to iron. Many, many moles of iron bind to 1 mole of ferritin. Where is ferritin? Where does it occur? Well, ferritin occurs in the reticuloendothelial system. Reticuloendothelial system is really a very simple thing. It's only one type of cell. That's a macrophage. So ferritin exists in macrophages and binds to iron. When it's time for the iron to be utilized, then through a so-called reversed endocytosis, the iron is flipped through receptors on the inside of the macrophage, outside the cell, where it fuses with the red blood cell, and the iron gets shoved into the red blood cell to form a complex with hemoglobin, and of course in the ferrous state where it can bind oxygen. That's the basic mechanism for which this happens. Now think about this for a second. Here you have ferritin being stored inside macrophages, and the macrophages hold on to it very jealously. However, this jealousy can only go so far, and some of that ferritin that's being synthesized inside the macrophage leaks outside the cell. So there's an equilibrium between the intracellular ferritin and the extracellular ferritin. Now, it's obvious that if all of a sudden something happens to the macrophage where this magic demon suddenly sucks up all of the ferritin that happens to be present in the macrophage, then there's no way that any ferritin can come out of the cell, so the serum ferritin is going to start to fall. In other words, the serum ferritin actually reflects the ferritin that's present inside the macrophage. That's the lion's share. But the small share is what we use to be able to diagnose whether or not the stores are appropriate. Now, the ferritin ranges are fairly wide. They can range anywhere between 20 and 100, roughly, for ferritin levels. However, the point is that if you have a patient who has a hypochromic microcytic anemia and his ferritin is, say, 19 or 20 or even 25, already he's got a very high index of suspicion that on the basis of the ferritin that he is got an iron deficiency anemia, an IDA. Now, what's the other possible diagnosis other than thalassemia? We know thalassemia doesn't usually cause an anemia because the red cell count is normal, even though it's low normal. What is the other possible cause of a hypochromic microcytic anemia? Here's the third cause, ACD, anemia of chronic disease. Now, this is a catch-all term. It can mean patients who have cancer, patients who have TB, patients who have chronic infections, inflammatory processes such as systemic lupus erythematosus, any other collagen vascular disease, even rheumatoid arthritis, if it's serious enough, can cause the anemia of chronic disease. What the anemia of chronic disease simply means is, for some reason that we do not understand, the red cells are small and are not getting their normal complement of hemoglobin. But what is true of these cells, however, is that they have enough iron. There is no deficiency in iron storage. Therefore, in the anemia of chronic disease, the ferritin levels will be absolutely normal. So if you have a patient with a hypochromic microcytic anemia, and you got a ferritin level of 50 or 75 or 100, something like that, that patient absolutely does not have an iron deficiency anemia. The patient has to, by diagnosis of exclusion, have the anemia of chronic disease, and that is it. Now, having said that, let me give you one caveat, and then I will show you some other things that you can fall back on as a second line of defense in making your diagnosis of whether or not this is IDA, IDA, or ACD. The caveat is this. It turns out that in the blood, you have a bunch of proteins. And those proteins are, and we'll show you this next time, by serum protein electrophoresis, we can separate them out into fractions. Albumin is the first fraction, then there's alpha 1, alpha 2, beta, and then you have the immunoglobulins used to fight off infections. And that's the way they separate out. It's beautiful how this can happen. But let me just call your attention to the fact that all of the alpha and all of the beta proteins suddenly will shoot up in acute inflammatory processes. Infection, a flare-up of SLE, a collagen vascular disease, just a local inflammation, an abscess, any of these things can cause a sudden shoot-up, a rise in these proteins, the alpha and beta proteins. These alpha and beta proteins are therefore referred to as acute phase reactants. Now, it turns out, most unfortunately, nature plays one little dirty trick. So far, it's been on our side. Well, we can allow it one. And that is that it turns out that ferritin is an acute phase reactant. It's a beta protein. It comes out in the beta region in serum protein electrophoresis. Therefore, you can have a patient who has an acute bleed, but an acute inflammatory process. The acute bleed is going to push the ferritin down, but the acute phase reactant part of the inflammation is going to push the ferritin back up again. Compensates, but not exactly. It always turns out, in those cases, fortunately, 99% of the time, the patient will have, at the very best, a low normal ferritin. Once again, you have to be on the lookout for that. Now, this points out something else that I want to bring to your attention, which is very important. Never make a diagnosis on a single laboratory value. Look at the trends. How many times have I had clinicians come to me and say, your upper limit of normal of calcium is 5. My patient had a 5.1 calcium. What is going on here? Why is your lab unreliable? This patient does not have clonus. He doesn't have tetany or any of the things associated with hypercalcemia. So the next thing you got to say is, did you repeat it? And the answer is always, no, you had this one value. Well, that's not enough. It's not nearly enough. So send us another one. And then the value will fall to 4.9, which is in the normal range. You've got to look at the trends. Don't make the diagnosis on a single value. Here you have a patient who comes in. Suppose the patient starts off with a ferritin of 75. And now, all of a sudden, the patient's ferritin drops. Let's say it goes down to 30. That's a hell of a drop. That's a lot. Goes down, but it's still within the normal range. Now you notice he has a hypochromic microcytic anemia. What is your conclusion? Your conclusion is, I'm looking at the trends. His ferritin is dropping continuously. This has to be iron deficiency anemia, even though the actual value may still be within the normal range. It's dropping. There is a trend showing it drops. Don't be afraid to order multiple tests. It's good for everybody. That's very important, and it will help you make the diagnosis. Watch the trends. So that's the key here. The patient comes in with a certain value of ferritin. The ferritin value drops. Your diagnosis is made, IDA. If it doesn't drop and it stays in the normal range, it's a hypochromic microcytic anemia, anemia of chronic disease. Now you got to find out what is the chronic disease. You may already know that, in which case it is consistent with your findings. On the other hand, you may not, and now you want to do a workup. So that gives us the basic use of ferritin. Now there are a number of other tests that we can go to, and I can show you what these are. They are far less reliable, take my word for it, than ferritin is. The first, of course, is the iron binding capacity. Now you all know, what is the iron binding capacity? Well, the iron binding capacity simply is a reflection of the amount of another protein in serum called transferrin. Now, transferrin is a molecule which dietarily actually goes into the bloodstream and into the gut, into the villi, in the mesenteries, and the mesenteric circulation in the villi, and actually transports iron across and brings the iron in, and actually brings transferrin to transferrin receptors on the surface of macrophages, where the iron is flipped by true endocytosis, receptor-mediated endocytosis, into the macrophage, where it's stored then as ferritin. Now, transferrin has two sites of binding per molecule for iron. And so the iron goes on to transferrin, and et cetera, et cetera. Now, generally speaking, there's a lot more transferrin than there is iron. That is, there are more receptor sites than there is iron available. So the body is circulating an excess of transferrin around. Now, if the iron falls relative to the amount of transferrin that there is in the body, the ratio is usually 1 to 3. If you look at the iron levels, the iron concentration in serum, and you look at the iron binding capacity of serum, which really is a reflection of transferrin, that gives you a ratio of about 1 to 3. If that ratio should become less, like 1 to 5, 1 to 6, or 1 to 10, the only time you will see that is an iron deficiency anemia, simply because the iron is falling off a lot faster than the receptor sites for that iron. That's what happens in bleeding. And that's the most common, by far and away the most common cause of an iron deficiency anemia. Now, that's extremely important that you recognize that. Again, this is by way of trend. Watch the trend of iron to iron binding capacity. Now, as the iron does plummet down, the IBC, the iron binding capacity itself, will also fall. So you can look at the IBC in a limited way, and you can look at the iron in a limited way, but it turns out by far and away the most sensitive measurement that you can get if you're going to use iron binding capacity is the ratio of the iron to the iron binding capacity. It should be around 1 to 3. If it gets down to 1 to 7 or 1 to 8, you can be pretty sure you've got an IDA. Take my word for it. Most of the time, you won't see it. It'll stay at 1 to 3, 1 to 4, but the ferritin will be low, and that's your answer. Once again, rely on the ferritin. Now, having said this, you can ask me, well, what about serum iron itself? Why doesn't that reflect how much iron there is in the body? If you rely on serum iron alone, you're dead in the water. Because why? Think about it. What is serum iron very, very sensitive to? Diet. What if you gave the patient leafy vegetables for supper? He had a lot of spinach. Well, there's an awful lot of iron. You know, you could have Popeye as your patient, for example. You'll have a person with high iron, and yet he may be bleeding. You can't rely on it. It just changes much too much for you to be able, and if you look at our ranges for normal levels of iron, it's mind-boggling. Forget about it. Don't even think about looking at that as an indication of being able to distinguish between these two conditions. Because iron changes too rapidly in serum, and it's much too sensitive to dietary loss. Much better as an indicator is the ferritin, as again I pointed out before. Finally, there's another measurement that we can make, and it's something I promised and I lied. I took 15 rather than 5 minutes to get to it. And that is what we call the RDW, the red cell distribution width. Let me show you what's involved when you look at that, and I'll get a nice clean piece of paper here and show you what happens. See, different cells, different red cells can have different sizes. If you look at the normal patient, the average distribution, I'll do it this way on the side first, then I'll flip it around so you can see it. Sorry about the slight disorientation here, but if I plot number versus cell size. Now you remember the cell size should be something like about, what, 80 to 100 femtoliters. That 10 to the minus 15 liters for each individual cell. And because of the fact we have these nice modern Coulter counters, we can measure the actual distribution of the size. By the way, there are two different ways of measuring the size of individual cells. You can do it by a voltage change. In other words, you have an aperture which forms part of a resistance to a current. And as the cell goes through, the bigger the cell, the bigger the blip in resistance is going to be. The resistance is related to the cell size. So you can actually record the size of the resistance change and count the number of such blips and then plot those number versus the actual size, which is calibrated. Such and such a resistance change had to be caused by a cell of a certain size, hence volume. So that's one way to do it. That's the way the Coulter system works. And so you'll see a distribution looking something like this. It's a nice, what we call Gaussian distribution, where you have a very well-defined mean. That might be, 85 femtoliters, and it might be plus or minus 5 on either side of the distribution. Typically, in the anemia of iron deficiency anemia, what will happen is that because different cells are getting different amounts of iron, especially in the non-steady state part, as you keep losing blood, some cells have more iron than other cells, the cell size begins to change, and you get a very flattened distribution that will look something like this. So what we do is we talk about the RDW, which is simply the width of the distribution at half the maximal height. So here is about half the maximal height, and here is the distribution. That's that plus or minus 5 femtoliters I talked to you about. Whereas over here, halfway up, you can see that the distribution is a lot larger. Well, that's just great. We can take use of modern technology and just by looking at the RDW and looking at the error, see if the patient has an IDA or an ACD. In ACD, by the way, the distribution remains absolutely normal. Why? Because the iron is normal. No lack of iron. So why can't we just do that? That's much faster. Just get it right out of that. The answer is you can't do that. The reason you can't do it is because there is so much overlap in RDWs between IDA, ACD, and normal patients that to make the distinction on that basis, you have to have so much bleeding that by the time you'd make a decision using the RDW for that, the patient will have exsanguinated. There's no point in waiting that long. This study was actually done by a good friend of mine at Bellevue when I was at Bellevue at New York University Medical Center. Warren Thompson actually published this and showed the RDW is completely useless as a method for distinguishing those two conditions, ACD versus IDA. At any rate, I just want to mention it to you because your attendings will tell you to order it, but you'll know within yourself, I'm relying on the ferritin. That ferritin is doubtful, I'll look at the trend. If the trend is doubtful, let me look at least at the ratio of iron to IBC, to TIBC, the total iron binding capacity. Let me look at that, and then maybe I can use the RDW if it's dramatically different from what it had been as the patient progressed on his course. So that's a hypochromic microcytic anemia. Now, let's talk about a very interesting type of anemia that we spoke about before, and that is the normochromic normocytic anemia. What are the possible causes of normochromic normocytic anemia? By the way, I want to show you something before I go on, and I want to illustrate to you the fact that there is a very, very tight relationship between hematology, hematopathology, and clinical chemistry. Notice to make the I can use my hematology to tell me I have an anemia and what type of anemia it is. But to be able for me to determine what the cause of that anemia is, I've got to go to clinical chemistry. Clinical chemistry is giving me my ferritins, my IBCs, my irons. The only thing that I said that is not clinical chemistry in this case is the red cell distribution width. So there's a very tight relationship between all these fields. They're all very highly interdependent on one another. Part of your workup is going to involve hematology, the other is going to involve clinical chemistry. They all work together. Now, what about the normochromic normocytic anemia? The most, by far and away, there are sometimes an iron deficiency anemia or an ACD, anemia of chronic disease, can give you a normochromic normocytic anemia at the beginning. Once again, you look at the trend as the patient is in the hospital or as the patient comes back to your office or it comes back to the clinic. You follow the count and watch what's going on in terms of MCV and MCHC. If the patient converts, already you know, I've gone from normochromic normocytic to hypochromic microcytic. This patient has got IDA or ACD. Now I got to get a ferritin. But if it's a constant, persistent, normochromic, normocytic anemia, there is one overwhelmingly common cause of that, and that is a hemolytic anemia. A hemolytic anemia can be due to many, many different things. By far and away the most common cause is an intravascular hemolytic anemia. The patient was put on aspirin, was put on some sulfur drug, which caused a cross-reactivity with an immunoglobulin that fixed complement on the red cell surface and caused an intravascular hemolysis. And that was the cause of the anemia. Sometimes the patient has an extravascular hemolysis. Very often, RH incompatibilities between maternal-fetal hemorrhage and the fetus, especially on a second pregnancy, begins to develop a severe normochromic normocytic anemia. You look at what the cause of that is, especially postnatal, when the baby is born, the newborn infant. You take a look and you see that there is a large spleen, and that's because the maternal RH antibodies have been fixed to the fetal red cells, and these are being taken out not intravascularly, but in the spleen by macrophages. And they're killing all the red cells in the spleen. There's always a splenomegaly in those cases of extravascular hemolysis. One thing you can do if you have a normochromic normocytic anemia is on physical examination, palpate the spleen. If the spleen is large, you've already got the direction to go in. Now, the question is, in hemolytic anemias, what are our diagnostic tests to tell us what is going on, to tell us exactly that we do have a hemolytic anemia? What can we hang our hats on to give us the answer to this? Well, the answer is it depends on the type of hemolytic anemia. And now I'm going to do something that people usually don't do. I'm going to divide the hemolytic anemias, not arbitrarily, it turns out there's very good reason for doing this, into two types of hemolytic anemia, not intra and extravascular. But I'm going to talk about production hemolytic anemias versus consumption hemolytic anemias. Most of the hemolytic anemias that you'll see are consumptive. That is, something's gotten to the serum somehow that's killing off the red blood cells. An antibody has been fixed to the surface. A drug has been taken. There was a transfusion reaction. The patient got the wrong type of red blood cells. God forbid. That's fatal. But it's something like that. That's a consumptive. But there's another type, which is a production. That is, you know that red blood cells are synthesized mainly in adults in the bone marrow. What happens if you do something to the bone marrow to mess it up so that it can't produce red blood cells anymore? That's a production hemolytic anemia. The red blood cells are fried right in the marrow before they can even get out into the circulation. Now, there are two separate, very characteristic patterns to make this diagnosis between those two. Let's talk about the consumptive first. First of all, you know right off what's going to happen. Suppose you were the bone marrow. You're producing red blood cells, and you get a signal coming back to you saying, hey, you're not producing enough. What are you going to do? Well, you'll produce more. And you're going to produce more and more and more. So, you know, it's like the boss telling you you're not doing enough. So you put out more paperwork, and you keep on doing more and more until finally you reach your maximum limit of stress. Well, what are you going to see in the red? You're going to see the paperwork in the peripheral circulation. What are you going to see? Well, you're going to see all kinds of precursor forms. You're going to see nucleated red blood cells, high reticulocyte counts, because the marrow is being stressed, because the spleen's been taking stuff out. You know, you can't go out and say, hey, spleen, stop. You're just going to try to keep compensating for what the spleen is unfortunately doing to you in taking out these red blood cells, or because in intravascular, your cells are being destroyed. You're putting out the reticulocytes. So the very first thing you do is look at the reticulocyte count. Is that reticulocyte count high? If it is, I got it. It's a consumptive hemolytic anemia. That's the first thing you look at. That's a hematology measurement. But there are other little things that happen that make it very nice for us to go about and very, very sensitive measurements of hemolytic anemia, especially incipient hemolytic anemias. Well, first of all, think about it. You have a hemolytic anemia. The patient has these red blood cells. He is putting out more and more reticulocyte counts. Let's say it's at the very beginning of the crisis, whatever it may happen to be. Took a sulfur drug. Maybe he has glucose 6-phosphate dehydrogenase deficiency, or elliptocytosis, or hereditary spherocytosis. Any of these conditions. Paroxysmal nocturnal hemoglobinuria. These are all terms. You don't have to worry about them. I'm just worried about the classifications right now. How do you make this diagnosis? All right, well, What would happen to you if you were a red cell and you had some antibody stuck to you? What's going to happen? Well, you're going to get into the spleen, and the macrophage is going to take a nice big bite out of you. If you make it through the first passage through the spleen, you're going to come out wounded. And you're going to look pretty wounded. So you're going to be fragmented. And that's what happens to the red cells. These fragmented red cells are called schistocytes. That is, they are fragmented cells. I'll show you what these look like in just a second. Many times the cells sort of crinkle up. I could actually draw you a picture, and the picture, believe it or not, is not even going to be as good as the slide is. This is one case where nature does a better job. In my case, it always does a better job. But anyway, here you'll see a cell that looks like this. That's called a Burr cell. Sometimes they look like starfish, in which case they're called echinocytes. A fragmented form looks like this. You know, a normal red cell looks sort of like that, just open, and you have an area of central pallor in the center. But these are fragmented forms, Burr cells. So schistocytes, Burr cells, echinocytes, any kind of fragmented forms, if that number goes up, and you'll actually get a count of that on the hematology report, that's an excellent indicator of a hemolytic anemia. Problem: if the spleen is large, if there's splenomegaly, and we can use this, of course, as I said, as part of our diagnostic armamentarium on the physical examination, splenomegaly, if the spleen is too large, it's going to take these cells out even on the first pass, so the actual count of such schistocytes, Burr cells, and echinocytes will be lower than it really should be because of the large spleen. So you've got to watch out for that. Now, in the clinical chemistry lab, we can do several tests, in fact 3 tests, which will absolutely nail down early on the diagnosis of hemolytic anemia. Think about it. What happens in hemolytic anemia, aside from the fact that the cells are being broken up? Well, once they're broken up, what happens? There's extrusion of the intracellular contents. What is inside the cell? You got hemoglobin. That's the main thing. Hemoglobin is 2 parts. You got globin chains, 4 of them, and each globin chain is bound to a heme. Each heme, in turn, contains an iron. The iron pops out. Let's not worry about the iron. Let's worry about the heme part, which is a tetraparole porphyrin ring, and the globin part. The globin part, very interestingly, binds, once it gets spit out of the spleen into the macrophage, gets into the circulation, to an alpha-2 protein, in the alpha-2 fraction, which is called haptoglobin. Now, haptoglobin, when it binds either to free hemoglobin or globin chains, suddenly makes itself seen to the macrophage, whence the hemoglobin originally came from, after the cell was digested, and all of a sudden the macrophage recognizes this, engulfs, and devours it. And it's destroyed. The whole complex is destroyed. Well, if that's true, we can measure that alpha-2 haptoglobin very, very conveniently by an immunoassay method, which takes all of maybe about 20 minutes to do the whole assay from stem to stern. In a hemolytic anemia, the haptoglobin goes down. Once you can show the haptoglobin has gone down, that is the diagnosis of a hemolytic anemia. That is the most sensitive test you can do. Haptoglobin. It will go down. It binds free hemoglobin and globin chains. Meantime, there's another side of the story, and that's the porphyrin ring. Porphyrin ring has 4 paroles on it, and it gets chopped up. Now, those 4 parole rings are linked in turn by these carbon atoms, these single carbon atoms. There are 4 parole rings and 4 so-called methine bridges. Remember that from biochemistry? Well, actually, biochemistry does have slight application here. So if you just remember that one part, that's all you need. One of those methine bridges gets chopped up, and the cyclic form of the paroles now becomes a linear chain of paroles. We're going to talk about this more next Thursday when we talk about liver function tests. But today, what I want to do is point out to you that the 4 paroles then stretch out. What do you think happens to that methine carbon that got chopped out to linearize the tetraparole? It goes off as carbon monoxide. That's good, because carbon monoxide binds to hemoglobin as carbaminohemoglobin. And we can pick that up spectrophotometrically beautifully by measuring a specific wavelength where this and only this occurs. And we can measure very small quantities of it. The most sensitive measure, therefore, Actually, for hemolytic anemia, is the earliest manifestation is an elevated carbon monoxide in the form of carbaminohemoglobin. And we picked that up with an instrument which is called a co-oximeter. And you have the right, as doctors, medical students, or whatever else you want to think of yourselves as being, I think of you as being doctors already, this is a test that you can order. You can say, I want to know about this patient. Could you please tell me what the carbaminohemoglobin content is? And if you see it's high, you've got your diagnosis of an early diagnosis of a hemolytic anemia. Most people don't do this. They wait longer. You can catch it early this way. As I say, it's a very sensitive test. Then, of course, you've got the haptoglobin. That's going to fall also. This is going on approximately at the same time. The changes in haptoglobin take longer. It's a big protein. But the oxidation of the tetraporol ring, porphyrin ring, happens instantaneously, and you can pick it up. Well, what happens when you oxidize the tetraporol linear chain further? You remember what happens. It goes to biliverdin, that's green, to this yellowish stuff, which we call bilirubin. Now, remember some of you may remember this, when we talked about liver function tests. The bilirubin gets transported from the spleen, macrophages, to the liver, where it's conjugated and excreted into the so-called enterohepatic system. It goes off in stool, et cetera, et cetera. Some of it gets recycled to the liver. It's conjugated as the glucuronide, mostly as the diglucuronide, to glucuronic acid. Now, if you have a severe hemolytic anemia, what's going to happen is you're going to suddenly shoot out a huge amount of bilirubin from the spleen. That hits the liver gets overwhelmed, can't process it all immediately. So there's a rise in serum bilirubin. But what kind of bilirubin is it going to be? Unconjugated bilirubin, that's right, unconjugated bilirubin, because it never got into the liver to be conjugated as the glucuronide. Now, infants can have very high unconjugated bilirubin levels. Infants can, remember, because we saw that there were 3 congenital anomalies or hereditary conditions that could give rise to inappropriate bilirubin metabolism. These patients often have bilirubins that are enormously high. The highest that total bilirubin should be is anywhere between 0.5 and 1 milligrams per deciliter. These babies, often with the inborn errors of bilirubin metabolism, can often go up over 20. Those patients are at terrible risk for developing permanent CNS damage, neurological damage, in the form of what we call kernicterus, where there's destruction of the basal ganglia. The unconjugated bilirubin becomes deposited in mainly the putamen, and they get movement disorders, chorioathetoid movements, and mental retardation secondary to this. Now, in adults, you almost never see an unconjugated bilirubin anemia unless there is a severe hemolytic crisis. So if your patient has a normochromic normocytic anemia, and you happen to do a 20-test profile on the patient, and the bilirubin comes back, let's say, at 2, and you look to see how much is the direct bilirubin, and it comes out to 0.1, and most of the bilirubin should be direct. Now, almost all of that 2.5, whatever it is indirect bilirubin, that is unconjugated bilirubin, then the answer is this patient must be hemolyzing. That's the only thing that could give rise to a dramatic rise in unconjugated bilirubin, so-called indirect. By the way, I use the terms interchangeably. Unconjugated is referred to as indirect bilirubin. Conjugated is direct bilirubin. There are historic reasons for that we don't really have to get in here today. We're looking at the clinical end of this, not the measurement end of it. So I just wanted to make sure you understood that. Already, I've given you, how many tests have we done now? So we can diagnose this. You can look at a slide and see schistocytes and Burr cells. You can look at the report and see schistocytes and Burr cells being listed. Normochromic normocytic anemia. I can have low haptoglobin, high carbon monoxide, high indirect bilirubin. That's a vast armamentarium. This is the way that you should go about doing this. Now, you're not going to, if you have a normochromic normocytic anemia, put your money on those tests, not on ferritin. You don't need ferritin now. You need these other tests. Now, if you order ferritin, I'm very happy. We can bill. But I don't want you to do that. I want you to aim to treat the patient. You got to know what the cause is. Once you've established the haptoglobin is low, my God, the patient is hemolyzing, what is the cause? What's the drug history here? That's your next question. Did the patient take drugs? Does the patient have a history? Where is he from? The Mediterranean? Is it a glucose-6-phosphate dehydrogenase? I want to go back and look at the slide. I want to see if there were valocytes or elliptis, elliptocytosis, hereditary spherocytosis. Is the patient putting out blood in his urine? Does he have PNH, paroxysmal nocturnal hemoglobinuria? That's a hemolytic anemia. All of these are the questions that you now ask yourselves. You see how it's directed, how you have to do exactly the test to remove the cause. If you don't have to transfuse the patient, don't do it. Stop. Get the cause away that's causing the hemolysis. Now, that's normochromic normocytic anemia. Finally, the last type of anemia that we spoke about is the macrocytic anemia, when you have a macrocytosis. Now, what is that going to look like, the macrocytic anemia? The cells are large, and as I told you before, it doesn't make any difference what the chromicity of the cell is, fortunately. By far and away, you want a number? I'd say 85 to 90% of the macrocytoses are caused by nutritional deficiencies. They are caused by two vitamin deficiencies, B12 and folate. Now, what lies in common between B12 and folic acid? You know what they do. They all aid in methylation, methyl transfer processes. By the way, so does S-adenosyl methionine. It's another cofactor you can think of as being an important methylating agent. But B12 and folate are quite unique for one thing, and that thing is methylating deoxyuridine to form thymidine. And then, of course, TTP, thymidine triphosphate, is incorporated into DNA. Now, if you don't have B12 and folate, you're not going to be able to carry out DNA synthesis. And if you don't carry out DNA synthesis, let me give you this rule of thumb. There are two places that are going to get hit the hardest. The first is the marrow. White cells and red cells are going to suffer terribly. That's the most rapid turnover of cells in the body. The second place that's going to suffer is the GI tract, because in the crypts, you're constantly making new cells. Skin, to a lesser extent, basal cells, and synthesis of new squamous epithelial cells, but mainly it's the gut and bone marrow. Why do I emphasize this? Because very often you're going to see patients on chemotherapy, and you know what chemotherapy is nowadays. It's a disaster. You take these agents that are nonspecific, they'll intercalate into DNA, kill DNA not only of the cancer cells that they're being used to treat, but also of cells that have rapid turnover. Where is the most rapid turnover? Bone marrow and GI tract. These are the patients who end up with infarction of the bowel, mesenteric thrombosis, and of course, they end up with pancytopenia. And you often see these patients in isolation rooms. Why? Because they're not producing white cells, no immunoglobulin, no T cells. They can't fight off infections. They're immune suppressed. So that's why it's important to keep this in mind. So, absence of DNA synthesis badly hurts the marrow system. And it affects the two types of cell lines, the white cell line and the red cell line. Now, the red cell line, something very funny happens. Cells are getting hemoglobin in, and they're getting iron. They're just fine. No problem there. But they're not getting enough DNA. And so what happens is the nucleus expands to get more DNA in, get more precursors in, but the precursors just aren't there. Why? Because there's no thymidine synthesis going on, because the B12 and folate aren't there to make thymidine. It can't use the oxyuridine. Some is going into ineffective DNA synthesis. You're making some DNA, but you're forming fragments. Cell enlarges to get more fragments in, to get more DNA in. So what happens, the net effect is that the cell becomes huge. If you actually look at the bone marrow in these patients, and you look at the red cell precursors, such as the pronormoblasts that you may remember from histology, when you looked at the bone marrow, these pronormoblasts, it almost looks as if the patient has leukemia of some sort, an erythroleukemia, where the cells are gigantic. They look like huge, huge precursor cells. That's all because of this ineffective DNA synthesis. The cell expects DNA and is not getting it, so it enlarges more. That's what is essentially at the heart of the macrocytosis that you see in the peripheral blood smear. Now, as I say, 85 to 90% of the macrocytic anemias are caused by B12 and folate deficiencies. Therefore, if you see a macrocytosis, an MCV, that is 100 femtoliters or greater than that, often it's 105, I've seen 110, what's the first thing you're going to order? B12 and folate, we do that. That'll take you about a half an hour, and you'll get your answer. B12 and folate, it's very easy to do, very rapid immunoassay. And by the way, the assays are going to become even more effective in the next couple of months. There's a whole new technique. It's fascinating what's going on in the diagnostic field. But these are, I just want to tell you, it's a very short period of time and very accurate numbers. Now, suppose the B12 and folate come back normal. What are you going to do then? Well, you got a problem. You got to think, what else could possibly cause this? Well, I can give you a cause right off the bat. Remember, you're looking at numbers coming off the machine, the Coulter. Now, this is one case where if the B12 and folate come back normal, you say, I got to look at the smear. What is it you're going to be looking for? Well, don't forget you're counting cell size here. Remember, if the cell size is big, don't worry about the chronicity. So what are you going to look for? Well, maybe the patient, for some reason, is producing an excess of precursor forms in the macrocytic series. So, for example, you have lots of nucleated red blood cells. There may be a very high reticulocyte count. So that may be giving a false elevation to the overall average red cell volume. By the way, in this case, the red cell distribution width is going to become enormous. And this is going to be a macrocytic anemia because the average is going to be to the right of the mean, but it's going to be very, very wide because you're going to have some normal cells, some very, very, very large cells, and cells sort of in between in a case where, for some reason, the bone marrow is being stressed, for example, in a hemolytic anemia, although that tends to be normochromic and normocytic, and it's producing these precursor forms of the red cells. So you look at the smear. And then when you look at this, there's an excess of reticulocytes and nucleated red blood cells. That's the cause of the macrocytosis. So this is one case where you'd actually want to look at the smear and take especially if there is severe discrepancy, if it's a large RDW, and in the face of what's called very severe anocytosis, differences in cell size, and poikilocytosis, differences in cell shape. That's all on the report. As soon as you see that in a macrocytic anemia, look at the smear. See if maybe it's the precursor forms that are actually causing this. Now I'm going to talk about those precursor forms in another context in just one moment. I'm going to come back to it then. Now, there's a third possibility. Believe it or not, reasons that aren't very well understood, common cause, about 10% of the time, the patient may be hypothyroid. Very, very important to remember this. Hypothyroidism, a low T4. Now, I'm not going to go into all of the ramifications of endocrinology today. We will talk about that in the course of our meeting next week. But what I wanted to emphasize to you is the fact that hypothyroidism can cause a macrocytosis. Now, therefore, after you've done the B12 and folate, after you've looked at the smear and ruled out the possibility that there's a nutritional deficiency over here and that there is no severe anocytosis, poikilocytosis, no excess amount of precursor red cell forms, now I think of the possibility, I got to get a T4. That's the next thing that you're going to order. Now, you could do this all at the same time, save yourself a little time. No reason you can't do it. T4s are instantaneous, a few seconds for that. But the fact of the matter is, these are the things you want to look for as the cause of the macrocytosis. Once again, you'll notice how most of the tests involve chemistry. You're doing chemistry on these cells, and you're looking at chemistry in serum to make your diagnosis from the cause of a hematological condition. Now, I want to go back to one other thing I mentioned just a few moments ago. You remember I spoke to you about an excess of precursor forms getting on the slide. And you remember from about 15 minutes ago, I said there were two types of hemolytic anemia. There was a so-called consumptive type, and the other was the productive type of hemolytic anemia. We talked about the consumptive type. That's the thing where you order the haptoglobin and you get the CO, carbon monoxide, or the bilirubin, and et cetera. It's schistocytes, Burr cells, echinocytes. But what about if it's a productive hemolytic anemia? Now, what do I mean by that? Now, this has direct implications for severe pathophysiology. It's what we call microangiopathic hemolytic anemia. Now, what do I mean by that? If you could say that 10 times without making a mistake rapidly, then you could graduate from medical school right now. Microangiopathic hemolytic anemia. I can't even do it myself. Anyway, but the point is, what this means is it's a disease of the small blood vessels in bone marrow. Now, what does that mean exactly? It can mean a lot of things. One thing it can mean is something happened to the bone marrow that got into the bone marrow and is killing off all that microvasculature where all these little incipient forms are coming out. Now remember that the white cells and red cells all have precursors. For example, you look at the white cells, let's say it's the myeloid series. You have myeloblasts followed by promyelocytes, followed by myelocytes, and then metamyelocytes. You've seen all this stuff. They talk to you about the leukemias. You talk about M1 and M2, depending on whether it's the myeloblast or the promyelocyte. And if it's not the promyelocyte, you have AM. You can have AML versus CML. CML, you have all the different precursor forms present on the slide at one time. All of these things. That's not what I want to get into. What I want to just tell you is there's a disease affecting this. What it does is it fragments and it hurts the membranes of both the white and red cell series. Now, it's interesting that what happens to the red cells in microangiopathic, angio meaning microangio, meaning small blood vessels, it's the same thing you see in the so-called consumptive type of hemolysis. The red cells form schistocytes, Burr cells, and echinocytes. The white cell series doesn't quite respond in the same way that the red cell series does. Sure, you could see fragmented white cell forms, but remember the white cell count is always much lower on an absolute basis than the red cell count is. The red cell count is on the order of 5 million per cubic millimeter. The white cell count is on the order of, 5 to 10,000. You got about a factor of 1,000 difference between red cells and white cells, so you don't tend to see those fragmented forms nearly as much as you do with the red cells. But what you do see in the white cells, and what nature provides us with, is that the white cells suddenly say, hey, I can't get these white cells out into the circulation. Well, if I can't get them out, I'll throw out my precursors and let them do whatever they can do, for better or worse. All of a sudden, you start to see things like myelocytes and metamyelocytes, and then you see these band forms instead of the true lobated forms of the neutrophil series. And so you have what is referred to, and even the red cells respond to a certain extent this way. Some of those precursors get released also. Nucleated red blood cells, a couple of reticulocytes might come out. So you start to see this, a few nucleated red cells. You see myelocytes and metamyelocytes. We call this the leukoerythroblastic picture. That is, the preliminary release of white and red cell precursors with a lot of schistocytes and Burr cells, as you would see in a usual hemolytic anemia. If you see a hemolytic anemia accompanied by a leukoerythroblastic picture, that already diagnoses a production hemolytic anemia. Now, it's very important for you to recognize a production hemolytic anemia. Why? Well, what is a very common cause of that type of hemolytic anemia? Trauma to the marrow, space-occupying lesion, cancer, metastatic cancer. Very, very important in the differential diagnosis. Here is where you've got to get a bone marrow biopsy. As soon as you recognize that, from the picture, you get a bone marrow biopsy. Why? Because there may be a cancer. Another thing that can cause it is simply reaction of the marrow and replacing an inflammatory condition with fibrous tissue. We call that myelofibrosis, and often it's accompanied with liver production of red blood cells, the way it did in the neonate, and we call that myelofibrosis with extramedullary hematopoiesis, MMM. Now that is a not too uncommon condition. Again, it has to be made on the basis of a bone marrow biopsy, but you, looking at the values, looking to see, I got myelocytes, metamyelocytes, and schistocytes, I've got to have a production hemolytic anemia. Remember, the anemia is normochromic normocytic most of the time, by 99% of the time, almost 100% of the time. So there is your differential, part of the differential diagnosis. That's where you might see sometimes a slight shift from the normochromic normocytic picture to the macrocytic picture. That's where, when you look at the slide, you'll see the myelocytes, metamyelocytes, and nucleated red blood cells. Now, what other conditions might cause this particular pattern to occur? The last, and just the last thing I'm going to mention as part of the differential diagnosis of this condition, the last thing is an inflammatory condition secondary to generalized angiopathy caused by antibodies that cross-react with endothelial cells. That'll happen throughout the body. There is a terrible disease called thrombotic thrombocytopenic purpura, TTP. You've heard of this. What is the cause of TTP? TTP is simply an antibody to the endothelial cells in capillaries. Well, there are capillaries in bone marrow, there are capillaries in the kidneys, there are capillaries in the brain. What's very interesting about TTP is to make the diagnosis of TTP, it's a very easy thing. You have the leukoerythroblastic picture, you have a production hemolytic anemia, you've got all that, and the patient will have renal failure. Why? We're going to go into this in just a minute. Renal failure because the small vessels are being affected, and you infarct the kidneys. But you don't just infarct the kidneys, you infarct the brain. These patients come down with neurological symptomatology. There are behavior disorders. There are movement disorders, sensory losses. The patients go under very rapidly unless this is treated instantaneously. It has to be treated as fast as possible, usually with steroids, to ameliorate the inflammatory condition that is giving rise to this. It's an antibody-mediated reaction. Very important then, if you see a patient who has the leukoerythroblastic picture, hemolytic anemia, usually normochromic normocytic anemia, renal failure, and neurological signs and symptoms, the patient has TTP. Now, one other corollary of this is the fact that the platelet count also drops, and that's why it becomes a thrombocytopenic. Thrombocyte means a platelet. So the platelet count drops also. Apparently, these antibodies also affect platelets. No one quite understands the pathophysiology of that. But I want to point out to you how important it is for you to be able to put those symptoms, to get those signs, these findings together to give you the picture of TTP. There's another picture, which is not quite as severe, where the brain, for some reason, is spared. But still the kidneys fail, and still you have the leukoerythroblastic picture, and still it looks like a hemolytic anemia, and that, of course, is HUS, the hemolytic anemic uremic syndrome. The pathology, the pathophysiology, is exactly the same. It's an antibody-mediated response, and it affects the microvasculature, causing this leukoerythroblastic picture, the hemolytic anemia, and the renal failure because of the small vessel disease. Apparently, it's not quite as widespread for reasons that aren't clear, but I think, in a sense, you can sense that HUS, hemolytic anemic uremic syndrome, is a form FRUST, that is a shortened form of a full-blown TTP, thrombotic thrombocytopenic purpura, where brain and platelets are further involved in the disease. The pathophysiology, as far as we know, is exactly the same. Now, so far, does this all make sense and hang together as to how you put these things together, how you put the lab values together, what to order and what to look for? Because this is all going to be directly relevant 2 weeks from now, and of course, throughout the rest of your medical careers. Now, having spoken about this, I now want to turn to a number, that's basically the red cell picture. I want to just turn very briefly to the white cell picture, just for a few moments. I don't want to go into too much detail on this. I want to just point out some very important findings that I want you to be aware of. Again, looking at the lab reports. Now, here's what, by the way, let me interrupt myself here. I'm very good at doing that. I want to just point out to you that the sessions are going to be a little long, and I apologize for that. I want to give you a crash course in these things, just so you get used to it. Now, I'm going to have this handout for you. I'm going to have another handout for you also, which is already prepared. It just has to be Xeroxed. And I give it to all our residents so that they keep all these things in mind. And I just want you to read through it. If you get through this, believe me, it will serve you in very, very good stead. Next week, we will have coffee and cake on me, so you can keep awake and alive throughout the course of this, because I realize it's a lot of material to cover at one time. Now, if you think I'm covering too much too fast, we can actually have another session, have one patient session instead of two, I can spread it out a little bit further for you if you like. I'm going to leave that up to you. This is an elective, remember, and it's just completely for your benefit. So let me know if I'm talking too much. You want me to shut up, I'll shut up. Or if you want me to go on, I can go on. Yeah.
Next Friday, we have a final exam.
Okay.
Our session's Thursday, so I don't know how, everyone will be thinking about farm colors.
Yes, that's a very reasonable thing to do. That's okay.
I don't know.
Well, I'll tell you what we can do. She mentioned that you have a pharmacology test a week from Friday. What I can do, if it's all right with you, remember this is informal. You've all got honors, okay? So I can meet with you. Instead of having it at the regular time, I can schedule a session any other time you want, usually at night. Nights are good for me. I work late at night, and I could be very happy to give a session at night. It could be on, if you want to do it, what is today? Today is Thursday. I can do it anytime on Sunday. I could do it Monday night, Tuesday night, Wednesday night even. So it depends. It's up to you. I can actually reschedule the whole elective. It doesn't matter to me. The only thing is I would like to make sure Sunday would be a bad day for the lecture part of it because I want to make sure this gets on videotape. That's the only difference I speak about. Well, anyway, if you can just, well, you're the class president, so I can communicate with you and we can decide on a time that's convenient, say next week. Maybe Monday night, because then that's far enough away if you wish. I mean, it's up to you. Entirely up to you. And by the way, I can schedule more than one session, too. And again, it's completely elective. There's nothing to worry about. There are no exams, and you're all going to do very well. All right, I want to go back to the white cell count story now. Basically, as I mentioned to you, the total white cell count is made up, is usually anywhere between 5,000 and 10,000 cells per cubic millimeter. White cells are larger than red cells, as you all know. The white cell series, grossly, is divided into two parts: the neutrophil line, the myeloid line, and the lymphoid line. Or some people call it the monocytic line, including monocytes and lymphocytes. Generally speaking, about 2/3 of the white count is due to neutrophils, plain and simple, in the normal individual. The other 1/3 is lymphocytic. A very small population of that is monocytic, eosinophilic, and very rarely will you ever see a basophil, for example, in this series, the myeloid series. Now, what happens in acute inflammation? Person has infection. He gets pneumonia, TB, any of these things. What happens to the white count? It shoots up. What are typical values for the white count? White count, generally speaking, is going to be around 15 to 20,000, max. Sometimes it's 12. Sometimes you'll see 13,000. It's significantly higher than 10, though. 10 or above points to infection. Now, very importantly, you must look at the differential count. It's important to order a differential count. What part of this count is due to neutrophils? What part is due to lymphocytes? If, for example, it's 80% neutrophils and 20% lymphocytes or monocytes, what do you got? You got a bacterial infection, or perhaps a fungus can do that, mycological infection. You'll see this very, very typically. Garden variety infections due to bacteria, UTI, urinary tract infection, laryngeal infection, pneumonia, any of these things, these will all be accompanied by high white counts, say 10 to 20,000, with predominantly a neutrophilia. What happens if the patient gets TB? Brucellosis. Well, we hardly ever see that anymore. Listeria, monocytogenes. What happens in a case like that? Well, what happens is that you get a high white count. But now you look at the differential, and suddenly you see you got 80% lymphocytes. Well, that's, of course, a whole different story. As soon as you see a lymphocytic reaction, think TB or possibly a mycological infection, occasional, very, very occasional. Cryptococcosis occasionally is accompanied with a predominant lymphocytosis. But also you got to think virus. The only thing that's going to kill a virus is not the antibody, but it's really a T cell. Think about the T cell. That's a very important consideration. So you get a lymphocytosis in those types. So that immediately point you to what type of culture you're going to order. You want to order viral culture, or you want to order bacterial culture? Very important consideration. What happens if a patient comes in with a white count of 35,000? And you look at it, and over 90% of the cells are lymphocytes. Now what do you got to start thinking about? Huh? Yes, leukemia. And the type of leukemia I think you mentioned was CLL, chronic lymphocytic leukemia. Very important for you to understand and recognize that. You see a very high white count, and most of the cells look like mature lymphocytes. This is in the peripheral blood smear now. Shouldn't be like that. You've got to think of chronic lymphocytic leukemia, and that is part of the diagnostic workup. I'm not going to go into that right now, but I just want to warn you that that is an important part of the differential diagnosis. Very high white counts. The number, the cutoff that I use is 25. If it's higher than 25,000 and I see mostly lymphocytes, I feel it's I go after CLL aggressively and we'll work it up. Now, having said that, let's talk about the reverse condition. What happened if the white count drops? Say it's 3,000, 3,500, something like that. Very low white count. What's the next thing you're going to look for? Look at the red count. Is the red count also low? Because if the red count and the white count are both low, we have a condition which is extremely serious and life-threatening called pancytopenia. And that can be caused by a number of different things. The patient could be on chemotherapy. The patient could have severe myelofibrosis. Then, of course, you look for the sequelae of that we just spoke about. In other words, you want to look at the smear, certainly the lab values, myelocytes, metamyelocytes, the nucleated red blood cells, etc. Those are the things you want to look for. What if you you have a normal red count, or it's relatively normal, you don't have an anemia, or if you have one, it's very, very marginal. Let's say you have a hematocrit of about, we actually didn't talk about hematocrit, we should have, but let's say the red count is something like 4 million. It's just low normal, something like that. What are you going to do in that, but the white count is low? What's the most common cause of that? And this is a pathological. Well, let's say the patient has a slightly rapid pulse and slightly febrile. Let's say the temperature is about 40 degrees centigrade, maybe about 102, 103 Fahrenheit. Pulse is speeding up, white count is dropped. What do you think of? This is very important. Gram-negative sepsis. Extremely important. If you see a low white count, that's the first thing that should flip through your mind as the cause. Now remember, there are trends. The patient may be, white counts vary a great deal. For example, between blacks and whites, blacks tend to run about 1,000 lower than whites do for their normal ranges. Women tend to be slightly lower than men. This kind of thing. Now, you look at someone who comes in, though, who had formerly a white count of, say, 6,000, and now it's 3,500, there's the trend that we're talking about. There is a significant reduction in the white cell count. Something's wrong. Look at the red count. Red count normal. If the red count is normal, now what we have to do is we have to go in and work that up further. Look for gram-negative sepsis. Why does gram-negative sepsis cause a low white blood cell count? The answer is it's not clear. Everything has been attributed to so-called endotoxins. As you may remember, bacteria, gram-negative bacteria, produce endotoxins, which are lipopolysaccharides. And they have strange effects on the membranes of white blood cells. They also have very strange effects on the capillaries, causing anastomoses, but arteriovenous anastomoses, which causes a decrease in perfusion of peripheral tissue. I'm not going to go into all that right now. Interestingly, in approximately 10 to 20% of patients with gram-negative sepsis who have low white blood cell counts, because, again, of the reasons that are not completely clearly understood, these patients present with a cholestatic pattern. Their bilirubins go up. The bilirubin is direct or conjugated bilirubin, and it might be 3 or something on that order. Remember, the upper limit of normal is about anywhere between 0.5 and 1. 1.2 may be the upper limit of normal in many adults for total bilirubin. And these bilirubins may be 3. All of it conjugated. So there's a cholestatic pattern, low blood cell count, low white cell count, I should say, points to gram-negative sepsis. These are patients you want to culture, especially fever, febrile, and if they have a rapid pulse. They're going into shock. Gram-negative sepsis almost always, if untreated, will cause shock. Now, that's all I want to say about the white cell count. Now, what I would like to do is to turn my attention from the blood picture, having shown you what you look at first in the overall blood picture, to some of the analytes that we measure commonly in the laboratory. The most commonly measured analyte, as you all know, is sodium. Sodium is the chief extracellular ion. Now, another very important analyte is potassium, and that's the most common intracellular ion. Sodium values always run around 140 milliequivalents per liter. Potassium is very tightly regulated, and it varies between 3.5 and 5 milliequivalents per liter. Now, what I'm going to do for you now is to show you, and then we're going to call it quits today. I'm going to show you what the most common causes of hyponatremia are. Those have to be corrected immediately. And then I'm going to show you the most common causes of hypernatremia, because those also have to be corrected almost immediately. In fact, immediately, because they can be lethal if allowed to go too long. Now, just like the red blood cell count and looking at the differential diagnosis of red blood cells, you play exactly the same game with sodium. Sodium reflects fluid balance, and I'm going to show you why and how. But before I do that, I want to go through the most common causes. If you can remember these causes, there are only 5 causes of hyponatremia, low sodium. If I can show you, if you can remember these, and you can remember how to distinguish one from the other, you'll have no problem in treating patients whatsoever and making the diagnosis. Now, here it is. These are the 5. These are the 5 basic causes of hyponatremia. Let me read them off to you. And by the way, this is in the order of frequency of occurrence of cause. The most common cause is overhydration. The patient drank too much. Second most common cause is abuse of diuretics, treatment of high blood pressure, hypertension, or congestive heart failure. Lasix is a particular violator of this. Secretion of inappropriate amounts of the antidiuretic hormone that we spoke about at the beginning of this little talk. Hypoadrenalism, sometimes Addison's disease, form of hypoadrenalism. Very commonly now, AIDS-induced hypoadrenalism. Nobody quite understands why. It's not Addison's disease. It doesn't give you the typical picture of Addison's disease. And finally, a rare condition that you will all see perhaps once in your careers, but you should still be alert for it. It's called Barter's syndrome. And you may have heard of this, but we'll talk about it in just a few moments. These are the common causes of hyponatremia. You have got to distinguish between them. All you will see is when the blood values come back on your patient report, it will say there's a sodium of 125. Now, what is the cause of that sodium? You have got to correct that. Why? Because if you let that go too long, you have a hypoosmolar solution bathing your brain cells. Those brain cells are going to explode. You're going to cause a cell rupture, lysis of the cells, and you're going to have CNS problems. This is a particularly severe problem in the pediatric patient. So you must be aware of it, and you've got to know how to correct it. Now, you don't just withhold fluid from the patient. You can't do that. That may be completely detrimental. You may kill the patient if you do that from a hypovolemia. So you've got to be able to know what the cause is and remove that cause. Now let's go over this and figure it out. How are you going to know from the value of sodium of 125, and it's a persistent value. It's not a spurious value. You have it repeated. Maybe 126 the next time, or even 130, but it's significantly lower than 140. How are you going to correct it? Well, the way you'll correct it, you've got to be able to make the diagnosis. And here is a very important principle that 90% of the clinicians I've come across don't do, and you must do when you get on the wards next year. Order a urine analysis. It is the urine analysis that's going to tell you what is really going on and what's the cause of that hyponatremia. Why? Because if the patient just drank too much water, that water is going to be excreted as water. This assumes normal renal function. If the patient excretes the water that he took in, what's the urine going to be like? It's going to be dilute. The urine will be dilute. Now, that's extremely important because take a look at condition number 3, secretion of inappropriate amounts of antidiuretic hormone. What is antidiuretic hormone? Antidiuretic hormone is the hormone that allows you to retain water from the renal tubules. Well, if you have too much of it, you bring in too much water. And if you bring in too much water, where does the water go in the kidney? Vasa recta. Well, the vasa recta part of the circulation. I don't care what anybody says. And if that's true, then sodium becomes very dilute. But what happens to the urine? You're pulling more and more water out of the renal tubules. Therefore, the urine becomes more and more concentrated. For example, urinary sodium goes up. Plasma sodium goes down. On the other hand, if it's overhydration, plasma sodium goes down, but so does urine sodium go down. Why? Because you're excreting a very, very hypotonic solution. It's water. The water you took in is the water you put out, and that's all there is to it. But you couldn't say that unless you had done a urine analysis. Now, this is the third most common cause, secretion of inappropriate amounts of antidiuretic hormone, and I'm going to talk about that in another second. But the second most common cause of a hyponatremia is diuretics, overuse of diuretics. Now, how does that get put together with anything? Well, the way this works is as follows. What do the diuretics do? They work on the loop of Henle. What do they do? As you may remember from physiology, many, many light years ago, it seems, I know, it inhibits the chloride transport mechanism, so you don't build up the countercurrent multiplier that you normally should have. Now, the countercurrent multiplier is giving you tremendous gradients of sodium in the interstitial space. The actual concentration at the tip of the loop of Henle is 1,200 milliosmolar, which is much higher than the osmolarity of sodium which is something like 280 in normal serum. The reason your kidneys do that is as a means of getting the water back in. Because if you have a very hypertonic solution, under the effects of antidiuretic hormone, you can shove the water in to dilute out that gradient. Now you could say, well, eventually you're going to dilute out the gradient so much that you're not going to have a gradient anymore. So what is keeping the kidneys functioning from retaining more and more water? Well, the answer is, of course, that you keep replenishing the gradient all the time by the chloride pump that you have in the loop of Henle. Now, that's the so-called steady state. Now, what happens if you give a loop diuretic? Well, a loop diuretic wipes out that whole mechanism. So now you lose sodium and water together, and the whole thing gets lost, and you keep pulling sodium out of serum. Of course, you're pulling water out also, which is the purpose of the diuretic in the first place, but you're losing salt in excess of water. And because of that, you again have a very dilute serum. Your serum is going to be about 120. The urine is also dilute simply because you've wiped out the whole gradient. You're losing sodium, but you're losing huge amounts of water also. The water dilutes out the sodium in the urine as well. So all that stuff that normally was in the interstitial gradient has now been dumped out and gotten into the urine. So you have a dilute serum and a dilute urine. Now, that looks just like overhydration. Now, for all practical intents and purposes, both of these can be treated in exactly the same way. You keep the patient in the hospital for 24 hours on a fluid-restricted diet. And if it normalizes, then already you had either this condition, one of these two conditions. Of course, you're not going to give the patient diuretics in the meantime. But there's another very simple test that you can do that instantaneously gives you the diet that can distinguish between possibility 1 and possibility 2. Most of the time, in overhydration, potassium remains normal. Why? Potassium is under very tight regulation in the body for the simple reason that if potassium becomes abnormal, you get cardiac malfunction instantaneously. I've actually seen people die from a hypokalemia, going into cardiac arrhythmias, and they die without treating the hypokalemia instantaneously. Very rarely does overhydration give you a hypokalemia. However, the use of diuretics almost always gives you a hypokalemia. Why? Because of the diuretic effect, but the sodium brings potassium along with it. I'm not going to go into the pathophysiology today. I just want to be able to get through this. We can talk more about this the next time, whenever it is you want to meet. But one quick way of distinguishing between overhydration and the use of diuretics in hyponatremia is look at the potassium. If the potassium is low, it's a diuretic. If it's normal, it's probably overhydration. Meantime, of course, you've looked at the urine to ascertain that the urine was also dilute for conditions 1 and 2. Is this clear so far? Okay, let's go on to condition 4. That's easy. Hypoadrenalism. What hormone does the adrenals elaborate aldosterone, exactly. What does aldosterone do? It works on the distal convoluted tubule to do what? You bring a sodium in, but you have to pay a price. You kick a potassium or a hydrogen ion out. It's a 1-to-1 exchange. It's not a freebie the way the loop of Henle was. So you gotta exchange a sodium for a potassium or a hydrogen ion. Now, what happens if that mechanism is not working because the adrenals aren't producing aldosterone? Well, you're not going to retain sodium in the distal convoluted tubule. You lose sodium. So the sodium concentration slightly goes up in urine. I'm going to talk a little bit more about this in a second. Now, however, if you look at serum, what do you see? You see a very low sodium, 125, 120, something like that. But what about the potassium? It's high, goes up, because you're not exchanging. There's also associated with this, because you're not getting rid of the hydrogen ion you normally would have, and that 1-to-1 exchange, there's a mild metabolic acidosis. We're going to talk about blood gases and how you measure acidosis next time. Mild metabolic acidosis. So, low sodium, high potassium, that's hypoadrenalism. Low sodium, low potassium, that's diuretic. Is that clear? By the way, again, you have measured the urine. The urinary sodium in this, and all except for this, should be low, lower than it normally would be. Okay, now that's for the first 4 of these. The last condition is rare. I'm not going to spend much time on it. It's called Bartter syndrome. These are patients who have persistently low sodiums and low potassiums, just like diuretic abuse. It looks just like a diuretic abuse, except there's one difference. You put them on a 24-hour fluid restriction in the hospital, and they don't respond. They remain hyponatremic and hypokalemic forever and ever. Family history. There is a family history always of the same condition. A brother, a sister, a sibling, father or a mother, grandfather or grandmother had this or have the same condition. So this runs as an autosomal recessive trait, but you can always pick up a family history with it. In fact, we had a case of 3 sisters about 3 years ago in this hospital, all of whom came to the hospital at exactly the same time. We knew the diagnosis, but it was really quite interesting to see. Thus far, here, in my 5 years, this is the only case I've seen of it. Nobody knows what the cause of Bartter syndrome is, but it's suspected that it's the following pathophysiology. There is a transport defect in the proximal convoluted tubule in potassium. So potassium is lost. Now, what happens if potassium is not retained in the proximal convoluted tubule? It carries its counterion along with it. What's its counterion? Chloride. Now, chloride, therefore, has to stay inside the tubules. Now, when it comes up to the ascending loop of Henle, it can't be pumped out anymore the way it used to, because it's got too much potassium. It has to stay back with the potassium. In a sense, the body is using potassium as its own loop diuretic, because now the potassium is holding the chloride. Now the chloride pump won't work, and the entire countercurrent multiplier gets thrown off. Not by a whole lot, but by enough such as to cause serum dilution again. So these are the 5 most common causes. And you know immediately, as soon as you pick up a hyponatremia, what are you going to order? A urine analysis. And what are you going to look for? Is the urine dilute or is the urine concentrated? Now, let me just define that for you very briefly in 2 ways. There are 2 measurements you can make instantaneously. Get the osmolality of urine or get the urine sodium concentration. What is the urine sodium concentration normally? It's about 25 milliequivalents per liter on a random urine. What is the concentration of sodium in urine in SiADH? secretion of inappropriate amounts of antidiuretic hormone, always over 40. If you use 40 as your cutoff, you're safe. So a patient who comes in with a serum sodium of 125 but a urine sodium of greater than 40 milliequivalents per liter, think no more. You've got the diagnosis. It's secretion of inappropriate amounts of antidiuretic hormone. Along these lines, the two most common causes of SIADH, A, head trauma, from trauma and or from seizures. Almost always a patient who has come as post-ictal, that is, because coming right out of a seizure, has just been taken out of, say, a grand mal seizure, will exhibit an SIADH. You'll very often see this on the wards. So you've got a clinical scenario that can back it up. Now, a patient who has some sort of SIADH and had been normal up to that point, there's a problem. Because a very common cause of SIADH is a tumor. Very often lung cancer will cause an SIADH. Why? Because it's the so-called paraneoplastic syndrome. Paraneoplastic syndrome means you make hormones. The tumor actually synthesizes and makes hormones that shouldn't be there. Parathyroid hormone is another very good example of that. Parathyroid hormone and antidiuretic hormone are two very commonly made hormones in the body, made by tumors, malignant cancers. Most common ones are lung and ovarian. Very, very common. We had a lady a few years ago with a colon cancer, and we attributed her SIADH to that because it wasn't going away. By the way, a cerebrally induced SIADH clears up by itself. It takes a few days, but it'll go away. And I just want to point that out to you. Osmolality. The osmolality of urine in the case of something like SIADH should go way up. Normal urine osmolalities are 300. In SIADH, the osmolality will be very high, over 400. The osmolality of serum will be very low, less than 290 milliosmolal. Another way you can make the diagnosis, just on the basis of relative osmolality. So now you have a complete diagnostic workup for hyponatremia. Now, the flip side of this is hypernatremia. Hypernatremia is easy because it'll be just the opposite of every one of these 5 causes, except that you can immediately eliminate 2. Let's start off. Overhydration, dehydration. How do you diagnose dehydration? High serum sodium, over 145 milliequivalents per liter in the serum, but the urine is dilute. Just the opposite of the urine is concentrated. Both the urine and the serum are both concentrated. Is there such a thing as not taking diuretics as being a cause? No, of course not. So you can eliminate that immediately. Now I come to secretion of inappropriate amounts of ADH. What if I secrete inappropriately low amounts of antidiuretic hormone? I can do that. That's perfectly legitimate. There can be 2 possible causes for that. Either there is a pituitary deficit in the secretion of ADH, in case there's low ADH, or just like in many other things such as receptor-resistant diabetes mellitus, you can be secreting enough ADH, but the receptors are not sensitive to it. You're not producing receptors in the distal convoluted tubule, in which case we refer to the disease as nephrogenic diabetes insipidus. Now, there are many causes attributed to so-called NDI, nephrogenic diabetes insipidus. Think of nephrogenic diabetes insipidus or diabetes insipidus in general as being a deficit in the production of antidiuretic hormone, and you'll be safe, functionally speaking. Can be treated just as that. So that's the opposite of secretion of inappropriate amounts, high levels of antidiuretic hormone. What's the opposite of hypoadrenalism? Hyperadrenalism, which we all know as Cushing's disease or syndrome. That is production of too much aldosterone. In this case, it's very easy to diagnose. You have too much serum sodium, and of course, the potassium goes shooting way down. And that can be very serious. That has to be treated very rapidly by giving potassium supplements. And of course, eventually removing the cause. If it's an adrenal tumor, you take out the adrenal tumor. Of course, you would then do an IVP intravenous pilogram and to see if there's a tumor in the adrenal gland and make the diagnostic workup that way. I'm covering a lot in a very short period of time here. I'm sorry about that. We can elaborate more. Finally, part 5 is there is no such thing as anti-Barter syndrome. So as you can see right off the bat, there are only really 3 causes of hypernatremia that you have to worry about, and here they are. Just to review them, dehydration. Now I put down diabetes insipidus or mellitus. Let's leave out mellitus for the time being. Dehydration, diabetes, and Cushing's syndrome. Those are the, I'll try to focus this a little, there we go. These are the basic causes of hypernatremia. Now, I have spoken about the kidney as being the major focus of all of these different diseases, and I was wondering if we started at 2, do you mind going an extra 10 minutes, or would you want me to shut up right now? Can I go ahead? Because I can cover one more thing, which is extremely important, that you will all you're going to face this almost on a daily basis. It's so important. Renal failure and how to diagnose it. It's so simple, and it's made so complex that unless we get it cleared up right now, it's going to take years for you to understand something that should take you just minutes to understand. Believe me, I know what I'm talking about, because it happened to me. So let me at least give you a little bit of lessons on this. There are 2 indicators of renal failure that we measure in the laboratory: BUN, blood urea nitrogen, and creatinine. Now, what are these 2 substances? Do they have anything at all to do with renal function? The answer is no, they don't. Urea is made in the liver. We spoke about this when I gave the liver function lecture. Remember, I told you that the only place that ammonia can be detoxified is in the liver. How? Through the urea cycle. All ammonia becomes urea, essentially, by the urea cycle, and it's excreted in the urine. And that's how you get rid of your ammonia. You detox it that way. Now, here's the question. Why does urea have anything to do with renal function? Well, the answer is it's just a fortuitous thing. Urea is very, very inert, which is fortunate. It diffuses very readily. It gets through everything, can cross any membrane you like, can get through anything. Soluble in everything. Soluble in polyethylene, soluble certainly in membranes, in blood, in water, in serum, everything. Now, of course, you know that it's in serum. It's in blood. And blood gets delivered to the glomerulus. And so it gets filtered through the glomerulus. It shoots right through the glomerulus, diffuses right across. In the same way that it gets across the glomerulus, it can get into the vasa recta and get into the renal arterioles and into the capillaries and be secreted by the kidneys into the urine. Now, the faster the filtration, the faster that the urea is filtered, the less urea you're going to have in blood. The slower the urea is filtered, the more urea you're going to have in blood. So I can write in a little equation, and I can write in fact, I can make it very simple. Let's get a free piece of paper here, and that's this. I can say that my blood urea nitrogen, or urea, it's the same thing, I'll call it my BUN, is going to be inversely proportional to the glomerular filtration rate. Because the faster the filtration, the lower my blood urea nitrogen is going to be. And the slower the filtration, well, the more urea you retain, because you're not getting it to the kidneys fast enough to get rid of it. So that's a very straightforward relationship. BUN in blood, normal range, 10 to 20 milligrams per deciliter. Now, what happens if you have a patient who has a BUN of 70? What are you going to say about that patient? Well, you could say one of 2 things. One is that his kidneys aren't functioning, so he's retaining his urea. Okay, that's fair enough. But let me play devil's advocate with you. His kidneys are just fine. The problem is his blood flow to his kidneys have slowed down. Oh, well, that's possible, right? I mean, after all, the glomerular filtration rate is proportional to the renal plasma flow. Remember that one? In physiology? See, these things do all creep in around the edges. all these principles one way or another. The urea cycle, now this principle from physiology. All right, anyway, so these things, so this works. So there are two possible causes. Now, both of them are associated with the kidney, simply because it's a filtration problem. Either there's not enough stuff getting to the kidneys, or there is enough stuff getting to the kidneys, but it's just not getting through the kidneys fast enough. High BUN says something's wrong around the kidney. It's either the kidney or before the kidney, that is the blood flow to the kidney. So we say it can either be a pre-renal cause, vascular, or a true renal cause, kidney. Let's turn to creatinine now. Creatinine is another story. Creatinine, again, has nothing to do with renal function. Creatinine is what? It's muscle. It's the way it's a muscle. Remember, we talked about creatine phosphokinase. You store high-energy phosphate in the form of creatine or creatinine, the cyclic form of creatine, phosphate. And when you need it, you just hook on that phosphate to an ADP to make ATP, split the ATP, and you've got your energy for muscle contraction, etc. So it's a muscle. So why do we care? It has nothing to do with kidney. What's going on? Do you remember way back in physiology they told you about inulin? When you inject inulin, if you measure the concentration of inulin in urine and in serum, and then you multiply the urine concentration times the volume per hour, you get the total number of milligrams of inulin that went through the glomerulus, right? If you divide that by the concentration of inulin in serum or plasma, same thing in this case, then that gives you the total amount of blood that was delivered to the glomerulus at that particular time in order to get that amount of inulin into the urine. Remember, it was that formula UV over P. Because inulin is never secreted nor reabsorbed, it's just filtered, then it is a true reflection, UV over P, of the glomerular filtration rate, the amount of plasma that delivered that amount of inulin to the glomerulus per unit of time. Now, it turns out that that exactly happens for creatinine. Creatinine is the body's own inulin. It turns out that creatinine is secreted, but at the same amount that's secreted gets reabsorbed. So it's as if nothing ever happened. So you don't worry about it. It's, for all practical intents and purposes, creatinine is just filtered, and that's all. Therefore, let's write the formula for creatinine clearance. Creatinine clearance, that is the urinary concentration of creatinine times the volume of urine per given time, divided by the plasma concentration of creatinine, is a measure of the glomerular filtration rate. Now, oops, I went off. Good, that's another piece of paper. All right, well, anyway, I'll put it this way. It's, we'll call it, let me write this more clearly so that when he takes a picture of it, I don't get totally embarrassed. Here we have GFR. Now, that's this one up here, over there. Okay, now, you have to watch what you're doing there and here. Anyway, so look, what I want to point out to you is the following. Suppose I have a patient now who has a delivery problem. The blood flow is low to the kidney. Okay, good, all right. What's going to happen to the BUN? It's going to go up. Less of it gets filtered. That makes sense. That's good. Okay, that's terrific. What's going to happen to the creatinine in a case like this? Well, let's take a look. Is anything going to happen to these terms, the urinary concentration of creatinine or the plasma concentration of creatinine? The answer is no. What is going to happen, however, is there's a change in the GFR. Why? Because the flow to the kidney was less. But creatinine, the kidneys are handling the creatinine perfectly normally. So the reason the GFR goes down in terms of what happens to creatinine is that the amount of urine you put out happens to go down. That's all. The amount that you just put through the glomerulus per unit of time went down, but the creatinine was filtered perfectly normally. Not true of BUN. BUN, urea, is secreted. And the faster the glomerular filtration rate, the more gets secreted, the more can diffuse through the renal tubules. That does not happen with creatinine. Creatinine is not secreted, net, at any rate. So the reason that there would be a decrease in GFR in terms of the urine and plasma creatinine has nothing to do with their levels. It has to do with the fact that the urinary volume goes down. In this formula, if V goes down, GFR goes down, and vice versa. Same thing. They're equivalent. Therefore, a patient who has pre-renal disease will have a high BUN but a normal creatinine. Now, sometimes the creatinine will go up slightly. Good. But the blood urea nitrogen will go up way in disproportionately higher amounts than the creatinine will. That's the first scenario. Now, what happens if it's not a pre-renal condition? What happens if it's truly renal? What are you going to do then? What's going to happen? Well, it's very simple. In that case, the GFR is going to go down, certainly, because the kidneys aren't functioning anymore. The BUN is going to go shooting way up. And exactly what happens to the BUN is going to happen to the creatinine. Creatinine won't be filtered, period. In the same way that BUN isn't filtered, creatinine won't be filtered, and therefore both are going to rise together. Now, think about it. What are normal levels of creatinine in serum? 0.5 to 1 milligram per deciliter. What is the normal ratio of BUN? 10 to 20. So let's take a ratio of about 20 to 1 as being the normal ratio of BUN to creatinine. Now, suppose you have a patient who comes in with a BUN of 70 and a creatinine of 1. What's the diagnosis? Pre-renal. It's got to be. What's the ratio of BUN to creatinine? It's 70 to 1 instead of 20 to 1, the way it normally should be. Take that same patient with a BUN of 70. BUN of 70 comes in with a creatinine of about, well, let's make it 5. It's a creatinine of 5. Well, 70 to 5 already is a ratio of what? It's 14 to 1. That's within the range of about 20 to 1, and therefore the diagnosis has to be true renal disease. Now, do you understand how you use BUN and creatinine? If the BUN is high and the creatinine may be slightly elevated, but the ratio of BUN to creatinine is way greater than 20 to 1, it's a pre-renal cause. There's a vascular problem. If, however, both go up, BUN and creatinine, such that the ratio remains within the limit of 20 to 1, then it is a true renal cause. Now I'm going to do something in 2 minutes that is going to allow you to not only tell me that there is a renal lesion, but you're going to tell me where the renal lesion is without doing a renal biopsy. And by the way, I'm going to do it completely non-invasively. I'm not even going to stick the patient. I've already got the BUN and I've already got a blood sample from the patient. That's all I need, one blood sample. Got the BUN and creatinine. Here's what I'm going to do. I'm going to ask you a philosophical question that you will not get the answer to. It's the only case where philosophy has practical implications. And here it is. What is the purpose of the kidney? Why do you have kidneys? What's the purpose of it? Anyone want to venture, just hazard a quick guess, quick answer? One answer is going to be to remove toxins from the body, to regulate sodium metabolism. These are all true, but it's not the reason that nature conceived of kidneys. The reason that nature conceived of kidneys is to retain fluids. That's why in physiology, some guy got up there, I don't know who it was, I can imagine what happened though. He got up there and said, you know, the desert rat has long tubules. Remember that I told you about the marmoset or whatever they call those desert rats, have these long, long loops of Henle? And you said, why do we have to memorize that? And then you got a type K question on it. You know, which of the following is true? You know, the desert rat, choice A is the desert rat has short tubules. Choice B, the desert rat has long tubules. This type of nonsense. The reason that they give you this is to tell you that the desert rat can't get water. So in order to conserve fluids, he has to have very long tubules, and that's the entire function of the kidney of a desert rat. Not to regulate sodium, but to retain fluids. That's why it's got very, very long tubules, to build up gigantic sodium gradients. Remember, the higher the sodium gradient, the more fluid is going to come through under the influence of antidiuretic hormone, ADH. Purpose of the kidney is to conserve fluids. One principle. Second principle is that the kidney is two black boxes hooked together. There are two compartments. The first black box is a filtration box. The second box is a concentration box. The filtration box is the glomerulus. The concentration box is the tubules. Now, here is what I'm going to do. I'm going to have this same patient come in with a BUN of 70 and a creatinine of 5. All right? I want to know, not only do I know that this patient now has renal disease, I want to pinpoint it. Is it in the filtration compartment or is it in the concentration compartment that this patient has his renal disease? And I can make the diagnosis instantaneously by doing exactly what I told you before. Measure the osmolality of urine. That's all you have to do. Measure the osmolality of serum. You've already got the blood sample. You did the BUN and creatinine on it. Now I want you to do an osmolality on it and very non-invasively have the patient urinate. Give you a urine sample, a timed urine sample. That's all you have to do. You didn't touch the patient to get that. Take that urine sample and measure its osmolality. What are you going to find? Well, if you put the patient on a fluid-restricted diet, the purpose of the kidney is to conserve fluids. Fluid-restricted diet, desert rat, conserve fluids. As you conserve fluids, you bring water in, and as you bring water in, that's under ADH, right? What are you doing to the urine? You're concentrating the urine. Conserving fluid is the same as the opposite side of the same coin of concentrating the urine. So the kidneys, if they're functioning, should, at least if the concentration box is functioning, the kidney should still serve to concentrate the urine. So you have the patient on a 24-hour restricted diet. He has a BUN of 70, a creatinine of 5. The ratio is 14:1, within the 20:1 limit. You now know the patient has renal failure. Now I check the osmolality of urine and serum. I find out that the osmolality of serum is 290 and the osmolality of urine is 320. I'm done. I now know the patient is concentrating the urine. Rule of thumb, the ratio of the osmolality of urine to the osmolality of serum should be 1.2 to 1 or greater. If it is, the kidneys are doing their job of concentrating the urine. Now I have the patient. Again, BUN 70, creatinine of 5, and now what I want to do is I want to find out where's the lesion. I measure the osmolality of serum, the osmolality of urine, and I find out that the ratio is 1.5 to 1. Where's the lesion? It's glomerulus, exactly. The patient probably has glomerulonephritis. Maybe it's maybe it's crescentic glomerulonephritis. It could be membranoproliferative glomerulonephritis, but you know the patient has a glomerular lesion. On the other hand, if the ratio is below 1.2 to 1, you know that the patient is not concentrating the urine on the fluid-restricted diet, and therefore the patient has a tubular lesion. Name a couple of things: acute tubular necrosis, ATN, papillary necrosis, renal infarction. Right, if Kimmel-Steele-Wilson lesion is in diabetes mellitus. We don't see it that commonly anymore. That's another tubular lesion. Anyway, I'll leave you with that. We covered a great deal of ground today. As I say, it's a crash course. I'll have coffee for you, cake next time, and we'll arrange a convenient time that will suit your needs.